And let me stop sharing my screen. And we got Susan Jones from You Speak of the Devil. Um, the main reason that we're doing this discussion today is that we have an amazing event scheduled at the Women's Club of Roland Park in Roland Park, in a Women's Club of Roland Park. It's on May 19th. Dr. Delia Chiaramonte, who you're going to be meeting today, is going to be our keynote speaker, but we're going to have interactive seminars, vendors, and much more. It's going to be a great event. Susan, tell us a little bit about the Women's Club. It's been around since 1896.
Absolutely, since 1896. So it was one of the first, sort of, I would say, not kind of commercial buildings that was on that stretch of Roland Avenue. It's the Olmsted Communities that was built, very tree-lined and beautiful. And these women got together in 1896 and decided to start a women's club. And in 1904, they bought the land, built it, got rid of the mortgage, and we've been here, kind of serving the community ever since. So we have, we're excited to have you guys here. I mean, it kind of fits perfectly with their mission. And we have most of our members are approaching retirement or have retired, although certainly not all. And so I think we expect a lot of our members to be here and guests. We are in a sort of a residential community, so we just ask that people who come just be mindful of parking and carpool when they can. But we, welcome you all. And there's information on our website. If you just go to the Women's Club of Roland Park, you can register and attend. So,
Yeah.
or by Zoom will be available as well. So,
Oh, wow. I did. Okay, this is exciting. I know some folks are not in the Baltimore area, wouldn't be able to attend. But if folks, if you can see on my screen, I just pulled up the website there, and I'm dropping it into chat as well. And it gives you this neat little pop-up that you can just click on the link, and then you go straight to a registration form, and you can get more info and sign up. And then the cool thing is that if you do RSVP, we're going to communicate with everybody who registers, so we can give you some guidance on, hey, here's what the neighborhood looks like. Here are the streets that, you can generally find a parking space. And I'm really delighted for two reasons. Number one, to support the members of this historic organization, but number two, to potentially invite some folks that might not have been familiar with the Women's Club, and who knows, you might get a few members out of this. Is it?
That would be wonderful. They'd be welcome. So.
Oh, this is great.
Thanks, Steve.
Well, Susan, thanks so much. I'll make sure to share this. And one of the reasons that we wanted to, and Dr. Chiaramonte, right? Tell me how I pronounce your last name.
Chiaramonte.
Chiaramonte. Holy cow. I practiced it 3 times before we went on, and I was like a deer in the headlights. And
no worries.
But we're really charged up to have this give people a preview of the wonderful speaker that you've secured as your keynote, and we're delighted to be a part of it. All right. So Dr. Chiaramonte. All right. Before we dive in, you've written this new book, and we're going to dive into that in a little bit more detail. But before we do that, let's get to know you a little bit better, and tell us a little bit about your background and what led to you this career path of caring for others.
Sure. Thanks so much for having me. I really appreciate it. So I started out as a family doctor, and I practiced family medicine for years. And I found a very interesting thing. When I was practicing family medicine, there were many patients that I had who felt miserable, but I couldn't find anything wrong with them. So they were tired, and their head hurt, and they had palpitations, but cardiology said nothing was wrong, and they just felt lousy. And I did all the tests and couldn't find anything, but mostly it was sort of life. They were unhappy with the way their life was. And then kind of by accident, I started doing hospice work. And I was shocked to find that many, not all, but many of the patients that I was seeing in hospice were happier, even though they had an illness that wasn't able to be cured. But here's why. I was so fascinated by that. But here's why. Once they were faced with that diagnosis, they stopped doing anything they didn't want to do. So they got rid of the people in their life that were toxic. They stopped doing things they didn't enjoy. They did way more of the things they did enjoy. And it turns out that when you live your life that way, you become happier, whether or not you have an illness that a doctor can cure. And
Wow.
so I really was struck by that, and it pulled me towards the field of palliative care. And so I became board certified in palliative care and changed my career into that direction.
Wow. I guess the phrase, and I know I'm going to botch this, but live every day like it's your last,
Truly.
is that many of these patients that you were interacting with were really taking this to heart by default. I mean,
Right.
it's probably hard for us to all, sort of slide into that way of thinking. But when you've been given a diagnosis, makes it a lot easier.
Yeah, but I would encourage us all to try to do that. That was actually what I told myself. Boy, why would I wait until I have an advanced disease to learn this lesson? How about I learn it now?
Man.
And, people say, oh, palliative care, it must be such a depressing specialty, but it's the opposite of that because so much of the focus is on living life now. And the truth is, not a one of us gets to stay here forever. Nobody. We all know
Yeah.
that. So
No.
if we can learn to live life now and really enjoy it now, it truly makes you a happier person. So we should all learn that.
And that what I've also discovered, because end of life discussions are something that we have frequently on this platform, that like probably like many people, I was hesitant. I mean, you get nervous in talking about this, but what I've found is they're the most thought-provoking, deep conversations.
Yeah.
And in generally, I feel better, and have a more clearer picture of how I want to live my life when talking about end of life. And
100%.
yeah. Now, the book, the subtitle of your book, A Heart-Centered Guide for Navigating a Loved One's Illness Without Losing Yourself. While you met these patients that may have seemed at peace with the end, and had a clear vision, and were setting priorities because they knew they 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 knew that there's limited time. As you remind us, we all have limited time, but they've been reminded now with the diagnosis.
Yeah.
But I imagine, because this is what we find on these discussions, the family and the people surrounding the loved ones,
Yeah.
they often are the ones that have the challenging communication, and need some redirection.
Exactly. And that is exactly why I wrote this book, because in my palliative care practice, what I found was there really were two groups of families. One group of families, it was a tough diagnosis, but the family pulled together and they're communicating well. And of course they're sad and of course they're worried, but the family is coping well. And then there was a whole other group of families where that was not the case, where it all kind of broke apart. The family kind of imploded. Nobody was talking to each other. They were cranky with each other. Everybody was kind of retreating to their own spaces. And the suffering of those families was so much higher, including the suffering of the patient. And so I really began to wonder, gosh, what are the families doing? The ones who are coping well, what are they doing? And if I take those things that they are doing and I teach them to the other families, will they feel better? And of course, it turns out, yes, there are things that you can learn to do that can make a difficult situation easier. And those are essentially the things that ended up in the book.
Wow. Now, we're going to dive in. I've got your table of contents I want to pull up here shortly. I just dropped the Amazon link into chat, but how long were you sort of refining this way of thinking before you wrote this book? Like what's sort of your time frame of this kind of learning this new way of your practice?
Well, I think the truth is, since I became a doctor, I have been learning, watching families, watching patients, seeing what it is that helps people. I did take a detour into integrative medicine. So for 10 years, I was the associate director of the Center for Integrative Medicine at the University of Maryland. And really the kind of medicine that I practice is integrative palliative care. So that is whole person care for families facing serious illness using all the tools that work. So medications for sure, sending patients for procedures, radiation, all those regular medical things, but also using evidence-supported tools like acupuncture and guided imagery, et cetera. And so over the years, I have learned both in my own personal self-care practice, and in watching the patients who are doing well. And I've been collecting tools basically since I was in residency, which is a long time ago.
Wow. Now, integrative medicine is something that a lot of people, when they learn about it, they get really interested in it. I just dropped a definition that I found on the Mayo Clinic website for everybody on there. But in layman's term, what is kind of integrative medicine?
Integrative medicine is a whole person approach to enhancing wellness. And that wellness can be either prevention, that's the ideal scenario. So some integrative medicine providers focus on preventing disease, but it can also be increasing the body's own ability to heal. So reducing inflammation, reducing stress, improving sleep, all of these things make our own physiologic processes work better. And so that can help people who have, for example, rheumatoid arthritis or lupus. That's an inflammatory disease. If you balance the inflammation system, their pain might get better. People who have back pain or knee pain, shoulder pain, neck pain, headaches can benefit from osteopathic manipulative medicine, for example. So this philosophy is wellness-based, but then it has a big toolbox. So the toolbox are things that are not generally taught in medical school: acupuncture, acupressure, aromatherapy, guided imagery, meditation, chiropractic, osteopathic manipulative medicine, Reiki, et cetera, et cetera, et cetera. It's a big toolbox. And actually having one foot in the integrative medicine world and then one foot in the palliative medicine world made me realize they should be together. So for palliative care patients, and I have to stop and say this, palliative care is not end-of-life care. Palliative care is the care focused on well-being for people who have a serious illness, even if you're trying to get cured. So if you have cancer and you're trying to get cured, palliative care is still appropriate, but why not have a bigger toolbox? That's how I see it. Why not use all the conventional medical stuff and add all of the complementary integrative approaches to help people reduce their physical suffering, emotional suffering, and spiritual suffering?
Great. Now, I did a quick look online for integrative palliative care. Is like the Integrative Palliative Care Institute, is that an organizing body of this practice?
So I started the Integrative Palliative Institute, and I started the Integrative Palliative Podcast. So my personal driving force is to create this field, which doesn't really exist. There's, that is a partner organization. So mine is the Integrative Palliative Institute. They're the Integrative Palliative Care Institute. And so both of us are focused on this idea of combining integrative medicine and palliative care, which is basically just, that's me.
Oh, okay, good.
That is.
I wanted to check. Yeah.
Yeah. So that I think it's so important, because here's the funny thing. Integrative medicine grew up as a field, palliative care grew up as a field, but they a little bit are in their own lane. And putting them together hasn't really happened much, but I'm trying to make it happen. So I have a whole program for teaching physicians and other clinicians about more tools to help people with serious illness, and then a whole pathway for families and patients to help in the same way.
Wow, I love it. You're really a pioneer here. This is fantastic. Okay. All right. Let's see. I want to dive into your table of contents, but I want to take a quick glance and make sure that we haven't sort of prompted any additional questions here. Let's see. Karen says, I started to see a palliative doctor in October. During my chemo, I was very miserable during chemo. I could not talk or walk. My muscles would not work right with pancreas pain. I saw I have pancreatic cancer. I saw a doctor and she changed my life. She changed all my medications and was finally able to have some quality of life. My family is amazed at the changes I am. And Karen, thank you, number one, for sharing that.
Truly.
You sort of started bringing tears to my eyes. This is one of the things that I love about this platform is when people like Karen share their real life story. And folks, it's great to share the solution in addition to the challenges. But now it sounds like this is palliative care working the way that it should be.
Yes, I would love to speak to that if it's okay with you. Um,
Absolutely.
First of all, thank you, Karen, so much for sharing that story. That is a story that we see over and over again. And this is why it's so important in my mind to talk about palliative care, because people sometimes hear that word and they think, oh my God, no, I don't want to think about that. Don't talk to me about palliative care, because they think it means end of life care, but it doesn't. It just means care focused on reducing suffering in people with serious illness. So some people with serious illness will be cured. Some people with serious illness will live for years with their illness. Some people will live a shorter time with their illness. But regardless, any time that you're here on earth, we should try to reduce your pain, reduce your nausea, reduce your constipation, reduce your depression, reduce your anxiety. So some doctors are focused on the disease, like an oncologist is trying to fix the disease. Palliative care doctors are 100% focused on the person and actually the family. Our unit of care is the person and their family. And our whole focus is reducing suffering, meaning making you feel better so you can live your life. So you can go out to lunch with your friends, you can play with your kids or your grandkids, you can live the life you want. So that's why in my mind, it's a little crazy that people are like, no, I don't want palliative care because they're saying, I don't want to feel better. All we care about is making you feel better. That's literally it. That's our whole thing. So my hope is that the more people learn about palliative care, the more they will say, oh, I got a cancer diagnosis or a dementia diagnosis or any other serious diagnosis. Sign me up. Where do I find palliative care? I want to feel as good as I possibly can feel.
Okay. Wow. This is great. I've really learned a lot. Uh and I think I mean, every time I talk to somebody on end of life palliative care, I get new information that helps me process this. Early on in my career, I had this vision that palliative care was just management of pain, that is what it was. Uh, you know, you've really expanded my vision that I knew that that was a pretty tight window there.
We do that. I will say we're experts in managing pain, and we will often use medications in ways different than conventional medical doctors that they don't feel comfortable with, but we do. But pain is not the only thing that reduces people's well-being. There are plenty of other things that reduce their well-being, and we're all about all those things. We just want to improve people's well-being. And to make the point even stronger, palliative care is appropriate at the time of diagnosis of a serious illness. So if you got a cancer diagnosis and you're hoping to be cured, but are you going to have symptoms? Yeah, probably, because you might have surgery and you might have chemo and you might have radiation and you might be anxious and you might get depressed and you might have conversations to have with a family that you don't know how to have. So all of that stuff, that's all stuff a palliative care doctor can help you with.
Wow. Okay. All right. So now let's dive into the book because I think that'll open some talking points and what have you. And I'm going to make sure to drop the link in one more time. I'm going to share my screen and show y'all. This is the where you can order it on Amazon. And then what I have done here is I've got your table of contents. And this seems to always be a fun way to get a glimpse inside and have a conversation with authors. I see that you've divided the book into three parts. Part one is navigating the challenges and take bold action. Part two is cultivate growth and build resilience. And part three is nurture authentic and meaningful connections. Um, Tell us a little bit about, the design of the book and those three parts.
Yeah, thank you. I organized it that way because I think those are the three big things that have to happen when you have a serious illness in the family. So there are things you have to do, right? You have to figure out how to manage the whole medical thing. How do you talk to doctors? How do you organize all your medicines? How do you get an advance directive? How do you talk to your family and everybody get together to deal with how are we going to manage mom's dementia? So there are things you have to do. That's the first part. The second part is more internal. So there are ways that you can grow. There are ways that you can tap into your strength. There are kind of deep, dark, hard things that you need some internal strength to manage. So there's the kind of the outside stuff you have to do. There's the inside stuff you have to cope with and how to learn to do that. And then the third thing is all about connections, because I think life is all about connections. And one of the things that being faced with a serious illness, I think really shows people is how important connections are. Connections with their family, with their friends, with other people in their life, with God, if that's important to them, with their pets. So that part I thought deserved its own section.
Now, I'm going to go out of order here because chapter 13 kind of uh, I have some curiosity about it. Avoid negative positivity. What is that? Because I have an idea, but I'd love to hear your definition of this and the solutions that we can go through.
I'm so glad you pulled that one out. We didn't plan that, but I'm so glad you pulled that one out because I think one of the biggest mistakes that people make is in that chapter. So the mistake that people make is adopting toxic positivity, and I'll tell you what that is. So toxic positivity is focusing exclusively on the, I'll put it in quotes, positive parts, because it's not really positive, but the positive seeming parts of something, and absolutely shutting the door on anything negative. And I'll show you how that shows up, and then we can talk about why that's not a great idea. So this would happen all the time in the hospital. A person would be in a hospital bed, maybe they had cancer, they earlier in the day had seen oncology, and oncology had said, gosh, that first chemo we did doesn't seem like it's working. We could try this other thing, but it's kind of experimental. I'm not sure if it's going to work. So I've had patients like this over and over. I walk in, hi, I'm Dr. Chiaramonte from the Palliative Care Service. And a patient would say something like this. Well, I don't know if it's going to work. Should I even do that chemo? Because the doctor said it might not work. And then here's what happens with the family members in the room. What? Stop that. You can't talk that way. Don't you dare talk that way. You have to be positive. I don't ever want to hear you talk that way again.
Mm,
Right?
wow.
Now, they're coming from love. They're trying to make a terrible situation somehow better. But what they do inadvertently when they act that way is they give the message to the patient, your fears are not welcome here. Right? We don't want to hear that you're afraid. So if by magic that took away the patient's fear, I'd be all for it. But the thing is, it doesn't. So all that happens in that little interaction is the patient realizes I am alone in my fear
And
and
now
I cannot share it.
and probably we're good. I imagine I can envision now I'm going to share less and I'm just
Yeah,
going to deal with this internally.
right.
Wow. And you're right. I mean, it's a statement like that, and we've heard it time and time again. Like, even as we're growing up and you throw your kid out to the soccer field, it's this, you got to get out there, and not giving somebody the opportunity to express their true feelings and then go out there. So what are some tips on that one in terms of, like, have you sort of re-scripted that dialogue, or how do you, if you were in that room, could you pull the family aside and kind of give them some guidance?
Yeah, I certainly would do that gently, of course, because they're doing their best too. I think, first of all, it's important to understand the concept and that acting in that way actually shuts down the loved one and kind of fractures the family. So in a family who was able to hear that, I would explain that. And so I think there's two parts answer to your question. One is, what are some communication tools, which we can talk about in a moment? Because partly why people do that is they don't know what else to say. They want to say something, They have no idea how to go in there with them into the dark place. So they just want to shut it down so it will go away. So one of the tools that I give people in general to allow space for both the negative and the positive is this little phrase that I use myself all the time, like every day. And here's the phrase: I really don't like blank, but at least blank. So I, or if you like the word hate, you could use the word hate, but I don't like blank, but at least blank. So, gosh, I really don't like that. I don't even know if I should do that chemo, but at least I have a family who loves me. I really don't like that I have cancer, but at least I have great doctors. But we can use this for everything all day long. Gosh, I really don't like that I had to go in the rain to that meeting, but at least I got a good parking place, right? So the point is, you make space for the bad also. You're not saying everything's great, everything happens for a reason, everything's great, because that's not realistic, and that can be hurtful to the person who's going through something hard. But you can always say, well, I don't like blank, but at least blank. So for that person in that example, we could say, the family could say, oh gosh, yeah, I wish, I hate that we don't know what to do. I hate that we don't have a great answer for your cancer, but at least we want you to know that we're here for you and we love you.
Man, wow. I've never heard this approach. I love it. I absolutely love it. And like folks, I know we're talking about end of life and diagnosis and this, that, and the other, but a lot of times this can be the communication with the family for, let's say, recently diagnosed as dementia, which could go on for years and years and years.
Yeah.
And adapting the way that we communicate with our loved ones as well. Okay, I'm going to read a few comments and then we'll jump back into the table of contents and some other points. Man, this is awesome. Ginger Smith is on this call. Folks, if go back to our recordings from last week, Ginger Smith is an individual who was in a nursing home for over 2 years, diagnosed with all kinds of, hallucinations, dementia, this, that, and the other, was placed on hospice and removed from all of her medicines, and she started recovering.
Wow.
And she says, I'm on palliative care and appreciate they are honoring my rare recovery. So Rick just ordered the book. Okay, Mike Hudson says, is there an organization of palliative integrative physicians that has chapters in other states? I'm interested in learning about whether there are these kinds of physicians in the New York City, Southern Westchester County area. Is there a way for people all over the country to get connected with practitioners like you?
So I would say that integrative palliative care is so new. I'm training physicians. So if you have any physicians that are in your network that you want to be trained, you could send them to me. But there are palliative physicians all over the place.
Okay.
So I think you can Google palliative care and your area, and you definitely could find someone. Sometimes palliative care is associated with a hospital. Sometimes palliative care is actually associated with a hospice, but the care you get from their palliative care people is not hospice, but sometimes they're the organizing people. So you could check with the hospices in your area and ask, do you have palliative care? If you choose palliative care from a hospice, it doesn't mean you're on hospice. It just means hospices are kind of branching out into palliative care.
Okay, great. Now, if somebody, if let's say that he's doing a search or what have you, is it okay to connect with you on the integrativepalliative.com site? And
Absolutely.
perhaps a physician in somebody's area. Okay.
Yeah, please reach out. I'm happy to help
Okay.
any way that I can.
Okay.
Absolutely.
Great. Let me drop that website in there again. And then, okay, let's see. Karen says, I'm a psychologist specialized in aging. I do hear clients feel responsible to be positive. This is why having a mental health clinician available to help process all the feelings and sometimes confront and help them with the family. I couldn't agree more. But
100%.
again, not just in this stage in life, it's all stages in life. The unfortunate thing is a lot of times for a lot of people, because I talk to them on a regular basis, their first experience and introduction to mental health support is when they've been diagnosed with a life-ending illness, and this is a lifelong journey that if you've practiced it in your 20s, 30s, 40s, 50s, 60s, it's a lot easier when you're faced with this.
100%. I would love to make a comment on Ginger's comment, if that's okay with you.
Yeah.
That is such an important concept that there's a whole chapter almost dedicated to this idea, which is managing the medical machine, and don't assume that what you hear from doctors, et cetera, is true. So the one place this often comes up is the difference between dementia and delirium. So this is in the managing the medical machine
Chapter
part.
3. Yeah.
Delirium is something that happens to people suddenly. So it can come from medications, it can come from infection, it can come from dehydration, and it causes confusion, but it looks like dementia. So if you just show up in the hospital and a bunch of people, doctors, et cetera, see you and they don't know you, they might assume that you have dementia. And dementia is progressive, right? Dementia is not just going to fix itself, but delirium can get better. And so the case in the managing the medical machine chapter that I talk about is the wife of this man who had this experience. She had to keep saying, and this is so important to tell the medical providers your baseline or your loved one's baseline. She had to keep saying, he doesn't have dementia because last week he was doing the New York Times crossword puzzle. So if you're confused this week, but last week you were doing the New York Times crossword puzzle, you do not have dementia. But when doctors look at you in a hospital bed, you look exactly like someone with dementia, and they may make that mistake. And so you always have to advocate for your loved one or yourself and say, this is not their baseline. And that can change the whole direction of how they take care of you.
And folks, if you didn't hear Ginger's story, I dropped it into chat. But, you know, Ginger went into the nursing home with basically one medicine, started getting diagnosis. When she was placed on hospice or around there, she had 15 different medications. And I think that I'm assuming that this is sort of not the vision of integrative medicine I mean, somebody might end up on prescriptions, but looking at the situation through a much wider lens.
100%. And this happens all the time. You get a medicine in the hospital and then you have a side effect, and then they give you a medicine to treat the side effect. And then that medicine is another side effect, and they give you a medicine to treat that side effect. And I'm not anti-medicine. I'm a doctor. I'm pro-medicine. Medicines are great. But this is a thing that happens in the hospital, particularly in a hospital setting where people don't know you. And, you know, you might have a hospitalist for 1 week and then they change to a different hospitalist. So you would have a totally different doctor next week. And that experience actually of people go on hospice and we take off some of their medicines and then they get better is not unusual, which tells you something about being on too many medicines.
Yeah, no. And we've had some discussions on, there's a new practice of pharmacists called deprescribing pharmacists that are helping, and I've got them looking at Ginger's list to see what kind of insights they have. But okay, now we talked about managing the medical machine. C. Conley asks, we need to get Medicare to acknowledge and include integrative physicians. Any ideas on how to do this? I love hearing insights from doctors on this sort of managed care insurance Medicare machine.
Yeah, insurance is not great, including Medicare. But I will say this, that physicians can bill Medicare regardless of if they're integrative physicians or not. So if you see an integrative physician, they can bill your insurance the same, because we bill based on symptoms and diagnoses. So if we're treating your migraine headaches, regardless of how I treat them, I still can bill for migraine headaches. So the physician can bill. Now, the place where it gets trickier is, how about your meditation teacher or a guided imagery person? Acupuncture is getting a little better. Medicare now will cover acupuncture for back pain only. But so sometimes if you're going to acupuncture for your GI stuff, they may say, do you have back pain too? Because they can treat you for back pain and bill for back pain and then throw in a couple of other needles to handle the other things too. So that's sort of a trick. But this is also why I think it's so important for physicians and nurse practitioners to learn this stuff, because I can be your meditation teacher. I can teach you about guided imagery. I can teach you about acupressure, and then I can bill a regular physician visit, because Medicare doesn't know what we did during the visit. If all that is to manage your migraine headaches, I can bill just the same. So if physicians don't know how to do it, then we don't get to use that. This is why I think it's so important for physicians to know more tools to help people manage their symptoms.
Yeah, so the solution to C. Conley's question and idea, which is great, is we just need to get more physicians aware, and I'm dropping in the Integrative Palliative website again. Forward that to your practitioners, and as they begin to weave this way of thinking into their practice, you're getting integrative medicine without, changes in your billing codes and things of that nature.
Exactly. And there's a lot that a physician can do in the office. So I'm not a massage therapist. I'm not going to give you a head to toe massage. But if you're having headaches and I feel that you have a trigger point right here, which where we all have them, right? A knot. As I'm taking your history and counseling you, I can be working on that trigger point and that knot, and I can treat that in the office. That doesn't mean I have to do a head to toe massage, because really this was the one spot that you needed body work just there. So there are ways that we can be targeted and learn skills that we can use for every patient that comes in. And why not? Like, why not have a bigger toolbox? It makes sense to me that everybody should learn these tools.
Yeah, no, I don't want to go too deep down the rabbit hole on changing the medical system, but I remember one of my good friends was a physician in a large family practice, and he had an accident and was trying to get back to practicing. And one of the things he told me is like, Steve, I have to see 36 patients a day, and I have to be able to hold my computer and this, that, and the other.
Yeah.
And I was just like, wow, the problem is not that you're recovering from this injury. The problem is that the system that you feel that you need to glide into is it's a treadmill,
Yeah.
the fact that you're just talking about, like, I mean, most of the times if we're talking to a physician, they're talking to us for 5 minutes and they run out the door. They're not sort of helping us with our trigger points. How do our practitioners change the way that they practice to embrace that?
That is a great question. Excuse me. And a deeper insurance question. The truth is, if you're seeing 36 patients a day, you can't give anybody too much.
No, exactly.
So partly, I think doctors have to kind of rise up and push back and have at least a reasonable amount of time with every patient. So ideally, if you could be in a practice where you get 45 minutes with a new patient and 30 minutes with an established patient, that's enough to do fantastic care. There are some practices where you are expected to see 4 to 5 patients an hour. It's much harder to do great care then, but then you do little bits at a time, right? Very little bits at a time. So while I'm examining your belly, I can say, well, I really do think that part of your headaches are due to the stress response. And when the stress response happens, all of these chemicals flood your body. And we have some things that can reduce that, including how we breathe. Here's a video that I pre-recorded that you can go listen to. Here's a sheet that I have in my pocket that I can give to you that's more about that. I want you to download the Headspace app right now. Why don't you do that right now while I go get your prescriptions? Do that right now. I'm going to come back. I'm going to say, all right, so you're going to listen to a guided imagery every night. And when you come back to see me in a month, let's talk about how that worked.
Now, I know it's going to come up. You'd mentioned an app, Headspace. I'm assuming this is what it looks like. Did I get the right one here?
Yes. And I have no connection to Headspace. It's not my thing. It just happens to be one of many really good guided imagery apps. So Headspace is great. Calm is great. There's one called Bootify, Insight Timer, and there are other ones. But what I found that was really helpful as a physician is asking people to download it in the office before they left. So if you just say, oh, try to listen to guided imagery, people go, okay, and then they never do that. So make it as easy as possible. Write down on a prescription, listen to Headspace for 5 minutes every night after dinner and give it to the person, because helping people with behavior change really makes a difference, really, really makes a difference. And doctors can learn how to do that, and nurses and nurse practitioners, et cetera, can learn how to do that.
Okay, I knew this was going to happen, that we were going to be talking about all these great things. And I'm looking at the clock. We got about 15 minutes till the top of the hour. I want to make sure that we kind of go over I think you've got 5 steps that, and I think you probably talked about a few of those, but you know, do you want to elaborate on that, and we can
Sure.
dive into that a little bit?
Sure. So it's, as you can see from our conversation, which could probably go on for 2 hours, there's a lot when you're dealing with a serious illness in the family. And I spent a lot of time thinking about what are the key things that families need to do in order to make this a more comfortable experience where their own well-being is not crushed. So in my mind, there are 5 things, and each of the things has, of course, ways that you can do that. But the big picture 5 things are: you have to learn to manage the medical machine, which we talked about a little bit. So you have to learn things like dementia versus delirium. You have to learn about the idea of medicines having side effects. You have to learn about how to organize all of your medical stuff, because you can't assume that Dr. A knows what Dr. B did with your medicines. You are the source of truth. And so you have to have an organized notebook. You have to write down your questions. You have to learn how to communicate effectively with physicians so they don't get defensive, but they actually give you what you want. So that's one: manage the medical machines, a lot of stuff in there. 2, you have to learn how to make high quality decisions, because there's a lot of decisions when someone that you care about is sick. And part of how you do that is you have to be willing to look at the hard stuff, because if you're hiding your head in the sand and you refuse to understand what's going on for your loved one, then you can't make good medical decisions. So you have to learn to talk about things that are going on. You have to learn to understand the other person's values, because decisions are based partly on the medical reality and partly on the values and goals of the person, the patient. So you have to be willing to talk about that and have skills to talk about that. And then you have to learn how to communicate those things to the medical team. So that's 2. 3 is you have to avoid making things worse. So we sometimes make things worse by our own challenges. Like if you're trying to control the uncontrollable all the time and you're trying to control every tiny thing, and then your loved one is getting angry and the doctors are getting angry and now nothing's getting done, that's not helpful. So there is some of the stress that's outside, and then there's some of the stress that comes from us. And so we can fix that part. So looking at how we're contributing and how we can fix that is really important. We have to, 4, learn how to manage strong emotions, ours and our families and our loved ones, because people are so afraid of strong emotions. That's part of what shoots them over to toxic positivity and makes them afraid to talk about anything. And then number 5, you have to learn to fill up your own cup, because having someone in the family who's ill or being ill yourself is a depleting experience. And if you're exhausted and wiped out, then hard things are harder. So it's so tempting to say, well, I'll get to my own well-being later, but you really shouldn't do that. It's important along the way to figure out, like, how full is your cup, what's emptying it, what would fill it, and make that be part of the plan. Because if you're a cranky caregiver, that's not good for your loved one. They don't want a cranky caregiver, right? So you got to take care of you so you can take care of them.
Man, I love this, and there's so much. I mean, again, why I like the discussions on that, where we tiptoe on end of life, is that, like, these are things that we all should be embracing. These 5 steps
Yep.
are things that we should be embracing right now in every part of our life,
Yep.
and like, so for example, I mean, we all know somebody who it's very hard for them to make decisions. Okay. And now you throw this on the pile, and the healthcare and the chaos, and you can see where
Yeah.
it's challenging for everybody. And it's kind of like, it's a reminder for all of us to if decisions are hard to make now in your life, sort of embrace that that's who you are, and think about the future. And if somebody close to you was ill, how would that way of thinking impact the situation? Man,
Yeah.
I love it. These are 5 great steps. I dropped them into chat there, folks. It'll be on the recording link too. So if you need that. Now, let me get back to a couple of the other questions that have come in. Owen says, does Medicare or any insurance recognize the cost savings value of integrative care?
Boy, I wish they did. That is such a great question. And we've talk about that all the time. We try to get them to understand little by little. Sometimes there are small demonstration projects, but Medicare is a big machine. But
Yeah.
we will keep screaming it from the rooftops, because you're exactly right. Preventing people from spending a ton of money counts as savings, but it's just not as easy for them to see as how much you cost.
Yeah.
But is a really important point.
And again, something that we talk about here a lot is that the machine, oftentimes it's sort of like, here, I can give you this pill and it's going to solve your problem, or it's going to get you out of my office. It's like, and having the hard talk is challenging. Okay. C. Conley says, does the integrative medical professional have to be the one that bills Medicare, or can the patient? Because a lot of doctors don't want to bill Medicare now because the process is so time consuming. C. Conley, we've got some discussions coming up on Medicare, so I'm hoping we'll be able to answer some of those questions there. But uh, do you have experience in this? Like, is it possible for a patient to bill Medicare, or does it have to go through the practitioner?
Well, so there are really complicated rules around Medicare and what doctors are allowed to do. So if doctors accept Medicare, they're not allowed to bill outside of Medicare. So there are some doctors who withdraw themselves from Medicare, which is the only way that they can have a full cash pay practice. So it's so complicated that I hesitate to answer that specific question, but I will say that you do have to find out from the doctor that you're seeing, are they accepting Medicare? Because some integrative medicine doctors don't accept Medicare. Almost all palliative care doctors do accept Medicare because they understand that's the population that they're serving.
Yeah. Okay. Now, Deborah has a good question, and I can't tell you, Deborah, how much this question comes up whenever we talk about anything medical. And she says, is concierge medicine the same as integrative medicine?
No. So concierge medicine is a physician's. So let me tell you first why people do it, because sometimes physicians get trashed for making this decision. Physicians who really want to give good care know that you need more than 7 minutes to give good care to a patient. And the way Medicare and other reimbursers are cutting reimbursement for doctors, it makes it so that to keep the same salary they've always had, they have to keep seeing more patients per hour. So some physicians have opted to get out of that system and instead bill in a different way. And usually that is something like you have to pay some amount per year to be in this person's practice, but in exchange, they limit their practice to a small number of people so they can really give you what you need. So a concierge practice like that could be anything. So it could be an integrative doctor, but it could be your gastroenterologist, could be your geriatrician, it could be your surgeon, it could be any kind of doctor who is opting out of the regular insurance system and asking you to help pay for the service so that they can give you good care. So I swear to you, they're not doing it to get rich. They don't make any more money. They're doing it so they can see fewer patients and give better care.
Yeah, no, it's and I can't tell you how many because we've all been sort of approached sometimes by our practitioners, hey, I'm shifting to this practice. And but it goes back to the story that I was talking about, my friend, 36 patients a day, holding the computer, the whole 9 yards. That's nowhere near what you're describing, how you're caring for people in your practices. Okay. It looks like we've got about 5 minutes to the top of the hour. And I want to make sure that I give you the opportunity to share anything that you may think is important that we may have not talked about.
Terrific. Yeah, there is one thing that I have probably taught to almost every patient that I've seen for the past years, which I think is so important. And it's not just about illness. I use it myself. It's for all of us to reduce stress and anxiety. So the idea here is that our mind can only be in one place at a time. It could be in the past, thinking about, oh, that thing that happened. Why did I do that? Why did he do that to me? It could be in the future, which is often worry. Oh my gosh, what if that happens? What if the cancer comes back? Well, I have a scan next week. Oh my God, oh my God, oh my God. Or It could be in the literal moment we're living in, like right here. So we're together, all of us on this wonderful Zoom and having a good time. So I have things I could worry about. You have things you could worry about. But if we focus on right this minute, most of the time things are okay, right? We're not starving to death. We're not way too hot or way too cold. Like right this minute, it's kind of okay. So this idea, and I have it on a piece of paper because I show people all the time. I ask people to put this on a sticky note. It says past, now, future, and put it all around the house. Because here's the idea. If you look at it and you think, oh, where has my mind been? If it's been in the past ruminating, bring it to the now. If it's been in the future worrying, bring it to the now. And the more you do that, the more you're like, no, I won't worry about the past. I'll bring it to the moment. The more you do that, the more your anxiety goes down. And you can use things like, what do I smell? What do I see? What do I hear? So you're in the kitchen and you're going, oh my gosh, I can't believe my kids did that. And what if they get divorced? Oh my gosh. You could say, all right, look, I'm going to be in the now. I smell the garlic cooking. I see the red peppers. I hear the sizzling. I hear the birds outside the window. I feel the knife in my hand. And if your mind's like, yeah, but what if they get divorced? You go, nope. I smell the garlic. I see the peppers. I feel the knife. And you do it over and over and over. And the more you do that, honestly, the happier you get. The less stressed, the less depressed and ruminating, the less anxious, the more content. It is probably the number one thing we all could do to improve our well-being.
Man, this is wonderful. You've really shared some amazing little nuggets that I think can really help us, those of us who are out there as caregivers. But folks, this is just, these great tips to just live by right now, because we're all going to have an end of this journey. And if we can live our lives this way now, we're going to make life better for all of the folks that are around us, more calming and less stressful.
Yeah.
Let me just make sure that I dive into a couple more, and then we'll wrap things up. Cedar says, and again, whenever we bring up concierge medicine, this comes up too. Concierge medicine only works for people that have a budget. When docs opt out of Medicare, some of their patients can't bill Medicare, and it's because that aspect of the practice is out of pocket. And I think that is true.
That's true.
And
That's true.
again, I know both of us wish we had our magic wand today that could solve that problem, but it's the other thing is that I've talked to people over the years. I'm not going to say that this is a general rule of thumb, okay, but if you've had a relationship with that doctor for many years, it's worth having a conversation about your financial well-being, and the fact that you benefit from that relationship. Because, as Dr. Delia said, is that this is just to enable this practice to serve the patients better. And it's not like every patient has to be charged this membership fee. There's no rule that says that, so there might be some flexibility there. If you have a loved one like that. Lots of great thumbs up and compliments on your presentation. And I have to agree with all of these folks. I can't wait until May 9th to hear you again in Baltimore. I dropped that link into chat there, folks. And I hope that if some of you are in the area, you come and join us. It's going to be a great day together. And just a reminder, this is recorded. We'll have the link at proaging.com shortly. And Dr. Delia, this has been amazing. You are truly, as somebody had said, you are truly a gift. And I tend to agree. You've been brave enough to kind of break out of the medical system that you had to work with, and think differently, and think for the patients and the families better.
I appreciate that. Thank you, everyone, so much for spending time with me, and thanks for the invitation, Steve. I really appreciate
you bet. All right, folks, we will see you all soon. Thank you again.